This is the 2014 ASPA lecture on pain and pain management, something that your patients in the snow will appreciate probably more than anything else you do. So let's talk briefly what pain is. There are all sorts of clever definitions for it, but essentially it's an unpleasant emotional and physical state associated with actual or perceived or potential tissue injury. And we're talking mainly about acute pain, that is sudden pain associated with an injury. Chronic pain is another kettle of fish associated with various chronic diseases and nerve conditions that we really aren't likely to worry about in our setting. The significance, of course, is that it tells you and your body that you're in a potentially injurious situation. So you accidentally put your hand on a frying pan that's hot, a number of behavioural and reflex responses to that pain will withdraw your hand from the source of injury. And types of pain, that's not really terribly important to us. The fact that there is pain is all we really need to worry about here. So let's just go through what happens when someone feels pain and just reinforce why it's a useful and adaptive behaviour. Where tissue damage occurs, certain chemicals, messages and substances are released from the damaged cells and tissues, and they trigger a response, an electrical impulse in these peripheral nerves, which transport that impulse through specific types of nerves into the spinal cord. Now at this level two things happen, and one of them is not shown here and one is. One thing that happens is that these pain impulses are transported up into the brain where a number of behavioural, psychological responses occur. So the emotional response to pain, the removing yourself from the source of injury response to pain, the anxiety and all the rest of it that we're all familiar with. Something that occurs at this level, which isn't mentioned here, is a reflex response, and it's the withdrawal response. And those of you who put your hand on something hot realise that you've actually withdrawn your hand before you've thought about withdrawing your hand. And it's a reflex withdrawal. The nerves that transmit the pain connect with nerves which control your muscles, and before your brain's had time to think about it, this little circuit's been completed and you've withdrawn yourself from the site of the injury, the source of the injury. Now, what happens up here in the brain, of course, is that not only is there a response, but there can be a modulation or a regulation of the pain. And the factors that govern that are really all up here. Age. People who are younger tend to respond more vigorously to pain. People who are fatigued tend to respond to lower pain thresholds than people who are feeling refreshed. Anxiety is a huge factor, and the relationship between pain and anxiety is very close. The more anxious someone is, the more strongly they will feel and perceive pain, and the worse behavioural response they'll have to it. Neurological function, that is, if you're alert, awake, clear-minded, you're going to have a much clearer perception of that pain than someone who might be partially demented, affected by drugs and alcohol, affected by a stroke, whatever it might be. And cultural factors I always put in, but there are certainly groups culturally who will express their pain far more vigorously for the same level of pain than other cultural groups, and without elaborating, I think we all are experienced in that area. So how do we control pain? You remember from the previous slide I emphasised the role of anxiety, and that's our first weakness in pain that we can attack. So we go along and we act professionally, we act confidently, we establish rapport with the patient and we reassure them. So what we're doing there is we're just capping that anxiety, bringing it down as best we can. And what's really important there is the power of suggestion. Don't go up to patients and say, "How's your pain? It must be horrible, that looks awful. How's your pain? How's your pain?" Go to them and say, "Gee, I reckon I can make you a bit more comfortable. We can probably make you feel better if we do this good thing." And the patients respond really well to those positive words. Don't focus on their pain or their injury. It looks amateurish, it sounds amateurish, because it is. It spoils your management. So be professional. Mechanical factors are hugely important. We talked about people with rib fractures automatically splinting their ribs. We all know that when we find someone with an injury, they're generally holding it. They're already splinting it. They're already applying some mechanical force to it. So immobilisation to stop movement, splinting, application of ice are all useful. Ice because of the standard rest ice compression elevation algorithm, but also because ice provides its own sensory input, which in some ways can counteract the sensory input that the injury is causing. And then we have our final rung in the ladder, which is the use of analgesics. So we're going to talk about the analgesics we use at the scene in ski patrol, and I'll not really spend any time talking about what's used later on, because that medical centre, ambulance, wherever it might be, stuff is beyond the scope of what we're talking about today. So we'll move on to Penthrane and Entonox, and we'll preface it by saying that those of you who've worked with patrollers from overseas or have worked overseas realise that we're in a very privileged position in Australia. We can use things, and we do use things that people in other civilised parts of the world have to go without completely, and we really are very lucky. So we have two things. We have Penthrane and we have Entonox. Penthrane is called methoxyfluorine, and it used to be used as an anaesthetic agent to make people unconscious for surgery many, many years ago. There are better things around for doing that now, so it's not used for that, but it was recognised at the time that it provided, as a beneficial side effect, very, very good analgesia in sub-anaesthetic doses. It's a gas, it's a volatile agent, so it's absorbed from the lungs, or from the air, into the lungs, into the blood, and then the blood transports it to the brain, where it has its effect, and the reverse occurs with its offset of action. It's got a very good safety profile, it's environmentally stable, it's easy to transport, it's easy to use, and I will continue to emphasise that it's completely safe to use in the ski patrol setting. In a little more detail, it takes about 6 to 8 breaths or 30 seconds or so for it to begin to be absorbed. It reaches its peak effect generally within about 1 to 2 minutes. The idea with both Penthrane and Entonox is that because the dose delivered is dependent on the patient's own behaviour, it can only be patient administered. And it's shown here with the wristband on, being patient administered only. I'm not going to go over the details of giving it because, again, that's covered in a prac, but simply we'll point out a couple of what I think are very important points. First of all, the Penthrox inhaler was a development of the original Penthrane inhaler. The idea being with this that it could deliver oxygen at the same time as the patient was using Penthrane. The design fault there is that whilst delivering oxygen into the back end of the Penthrane inhaler, you're of course evaporating the agent before it gets to the patient, blowing it out both the vents in the back of the inhaler, blowing it out the vent in top of the inhaler, and blowing it into the patient at increased doses. So rather than use the Penthrox inhaler, by all means use the inhaler, don't connect oxygen to it, give them oxygen from your separate independent source, either with nasal cannulae or a little hole cut with a pair of scissors in the side of a Hudson mask and put it in the side of their mouth that way. Okay. The respiratory cycle coordination is really important. I am at great pains to explain to patients to breathe out, to put it in their mouth, to breathe in through their mouth, hold their breath briefly, and then breathe out through their nose. Again, if they breathe out through their mouth, half of their respiratory cycle is being dedicated to blowing the drug away from them. Right? But if it comes out their nose, they're not interfering with the drug in the inhaler. So in through the mouth, out through the nose, and then I get them using the diluter vent as and if required. Contraindications to Penthrane, only two. One's an absolute and one's a relative. An absolute contraindication is if they can't use it. So if they are head injured and their conscious state is to the point where you can't explain the use to them and they can't coordinate it, clearly it's not indicated. And if they have a head injury, and this is the relative contraindication, but are able to communicate with you and you think they need pain relief because of other injuries, then whilst relatively contraindicated, it's still okay to use it to treat the pain. All right? And that's been a question that's been asked over the years. So the word is it's okay to use it as long as the patient needs it and can use it. Simple. It's mainly excreted from your body unchanged. There's partial metabolism of it. The metabolites generated, the amounts in which they're generated are of no practical relevance to us. Just remember, it's easy, safe, quick and effective to use. Moving on to Entonox now, which is also useful. There's some quite significant differences between Entonox and Penthrane, which I'll highlight. But Entonox does have its own role. It's a mixture of nitrous oxide and oxygen, 50% mixed. Nitrous oxide is known as laughing gas, and at concentrations just above 100%, so in other words unachievable, it can induce anaesthesia. But in this dose, it certainly produces a level of analgesia, although the analgesia with Penthrane is generated through a direct effect that's not well understood. The analgesia with Entonox is generated more through an effect of depressed conscious state. Most people who are getting pain relief from Entonox are getting it just before they become unconscious. Nevertheless, that's functional and useful in its own way. It's delivered from a pressurised cylinder via a demand valve, which has both benefits and problems. And because it's a large and rather cumbersome cylinder and has two gases in it with different physicochemical properties, there is the risk of separation of these agents. And generally, if the cylinder is stored below about -6 degrees Celsius, they separate away so that you've got oxygen on top initially, which is great, deliver lots of oxygen, no analgesia, and then when that's gone, you've got only nitrous oxide, at which point you get great analgesia and no oxygen. So it's important to store the cylinders somewhere warm, to keep them warm in the field, and to make sure that they're adequately mixed prior to their use. It's got a rapid onset and a rapid offset, much the same as Penthrane, although I would say the onset with Entonox is quicker than that of Penthrane. The offset is quicker as well. It really is closely linked to the time you're breathing on it, whereas Penthrane you'll get a little lingering effect when you stop using it. The other problem with Entonox is that it's flammable because it's 50% oxygen, so it supports combustion quite well. It's cumbersome to use, and it's contraindicated in any gas trapping type injury, so any gas space injuries. So ruptured organs in the abdomen potentially, not such an issue, but chest injuries in particular, where a pneumothorax can become rapidly a much more severe and large pneumothorax once nitrous oxide's on board in the patient's circulation. The main use that I think Entonox has is that we have a limited dose with Penthrane. We're allowed to use up to 6 mils in a 24-hour period. And if you're isolated with a severely injured patient, and if you've used up all your Penthrane, you're still looking at a few hours transport, by all means, as long as there's not a contraindication, the nitrous oxide can follow, the Entonox can follow on from the Penthrane and provide continued analgesia. And I would just refer you finally to an article that I wrote for the aspirations in July 2013, which is an up-to-date comparison of the science, the pharmacology, the costs. It's really an in-depth analysis and comparison of Entonox and Penthrane. It'll allow you to decision make well, so if you can track that article down, or perhaps it can be provided by lecturers, it's worth a look.